Well, a warm welcome to today's talk, Tuesday the 3rd of May. Now, the Danish authorities said they're going to let the virus rip. That was their terminology. In the United Kingdom and the United States, we've not said that, but we've said everything but, and this is de facto the policy now, and I want to show you about that in a minute. And I also want to contrast this to really the quite distressing things coming out of China at the moment as well. Just look at a few figures. This is straight from the CDC site in the States. So these are the number of cases. Now this is the BA1, the Omicron, huge bounce there, and the BA2 bounce is there, and I don't believe it's going to get too much bigger than that. So that's actually really good news. And when we look at the hospitalizations in the States, it's very reflective of that. We do see a slight increase at the moment in hospitalizations, but it's not really at a concerning level. Of course, we want less, but it's not really at a concerning level compared to this, the Omicron BA1 huge spike. Now, deaths in the States, down quite dramatically, but do bear in mind that this line here is still 1,000 deaths a day. This is 2,000 deaths a day. So we had that horrendous spike for representing the Omicron wave, but down really quite significantly now. And as I say, I'm not expecting a big Omicron BA2 bounce. Now, that is despite this graphic here. So here we have the increase in BA2. And here we have the BA2 12.1 subvariant of BA2, which is now increasing in prevalence in the States quite a bit. Now, this is also increasing in prevalence in the UK, and we'll have the data on that later this week. But I think there's been so much immunity generated by the BA1 and by the BA2 that that's going to create huge cross immunity now to this BA2 12.1. That's why I'm no longer expecting this sort of big spike in cases in the United States. So let's just have a look at what the new White House czar is saying about this. Quite interesting, really. So this is Dr. Czar, new White House spokesman, coordinator, czar, whatever you want to call him. Relatively low numbers of new deaths, but still too high. Now, he can't say anything else, really, can he? He can't come and say, well, 300 deaths a day is quite acceptable. He's got to say that's too high. And of course it is. He's quite correct. Hospitalizations, lowest point in the pandemic. Excellent. Going well. Rising case numbers. So there's rising case numbers, and this is a promising inflection. So the hospitalizations are down despite rising case numbers, which is good because there's so much immunity now present in the population. With such a contagious virus spreading, hard to ensure that no one gets COVID in America. Not very well put. But what he's saying here is it's hard to ensure that no one gets COVID. So, in other words, he can't stop people getting COVID, is what he's saying. You can't ensure that no one gets COVID. And of course, you can't. The Chinese are trying. They will fail. But it will cause huge amounts of suffering and economic destruction in the meantime. So Dr. Czar correctly realising that basically you can't stop this now. And in fact, that's not even a policy goal, which of course we completely agree with. We are moving on to the endemic phase. The goal of our policy should be obviously minimise infections. Well, should it? That's what he's saying. If you minimise infections, you'll minimise the amount of people in which you generate higher levels of immunity. You could argue that minimally symptomatic or asymptomatic reinfections are the best thing that could happen to stimulate natural immunity. But he's not saying that. He's saying they should minimise infection. So I'm going to put a question mark on that because I think it's a bit late for that now. To make sure people don't get seriously ill. Well, of course, we don't want people seriously ill. We are going to see cases go up and go down during the pandemic, correct? As we head into the weeks, months and years ahead. In other words, we're in an endemic phase and it is going to go down and up, down and up. And the cases will vary, but pretty soon I'm hoping we're not going to know because we're not going to be testing because the disease is not going to be that important. That's certainly the case in Denmark. More important reflections of progress, healthcare strain, of course, whether people are hospitalised and whether people are dying. These are the correct indices. That's why we've been focusing on that now for some weeks in this channel. Now, he did stress this is Dr. Jar, the White House czar. So basically speaking for President of the United States, Paxlovid needs a push to reach the vulnerable. Now, this actually surprises me. Now, I'm going to do a bit more on this because I'm going from memory of when the Paxlovid case paper first came out. But we did see that the Paxlovid gives quite a lot of protection in people that are not vaccinated and not have the infection. But of course now, virtually everyone has been vaccinated or had the infection, or indeed both. So basically we have no evidence that I'm aware of that Paxlovid is, or published evidence that Paxlovid is effective in the current population. And yet it seems to be getting encouraged by the White House here, who says doctors are too hesitant to prescribe the drug. Well, Paxlovid's not an FDA-approved medicine in the United States. Paxlovid is an investigational medicine. These are straight from the Pfizer. This is actually from the patient data sheet, published by Pfizer, of course. Some medicines may interact with Paxlovid and may cause serious side effects. If you take too much Paxlovid, call your healthcare provider and go to the nearest hospital emergency room right away. So, I don't know. There's a few question marks about Paxlovid there, and also bear in mind, I believe that the estimate in the Guardian that was published a few weeks ago was that Paxlovid was going to make $22 billion in 2022. It's an incredible amount of money. And what I suspect, we don't have the data here, but as Paxlovid is given to people that have got higher levels of immunity, I would expect you need to treat many more people in order to prevent a negative outcome. So this could become a phenomenally expensive process. And again, we don't really have the evidence that it is efficacious in patients with high levels of immunity. We know it's effective in patients with no immunity. There's no question about that. That prevents hospitalization. But does it prevent hospitalizations in people with high levels of immunity? We don't have the data. So basically what this comes down to is the White House pushing an intervention for which there is no current evidence, or little current evidence, at least in the peer-reviewed literature. So for groupings that are supposed to be scientifically driven, this is somewhat surprising. But I'm going to do some more on Paxlovid in a minute, because the story is kind of, it's becoming a bit nuanced, and Kamala Harris has just had it, of course, and she's highly vaccinated. So is there any evidence that it would be efficacious in the Vice President? I don't believe there is, and yet I think it's $500. I made a note, $530 for a 5-day course. And if we're rolling this out to millions and millions of people in the States, because there's going to be a lot of infections, it's going to cost a lot of money. More on that later. But there's a question mark over Paxlovid. But for now, we notice that Dr. Jar, the White House spokesman, basically representing Mr. Biden, the presidency, is promoting Paxlovid and criticising his medical colleagues for being reluctant to prescribe it. I'm not so sure. When you think how strict they've been and how they've come down like a ton of bricks on other things, for which there is perhaps more evidence, to promote something on such a weak evidence base for the current population is surprising. I'm not quite sure why they would do that. Why would they do that? Anyway, now there are some people in this country, this is back to what Dr. Jar is saying now, who think that we can take a domestic-only approach to this global pandemic. That's not a thing, you can't do that, but that's what the States has largely done. The global vaccination program has failed, I think we could say, fairly dramatically. Most countries have taken a somewhat closed-off, myopic approach, you could almost say. And fortunately, Omicron came along to promote immunity at minimal cost in terms of hospitalizations and deaths in poorer nations. It certainly wasn't the generosity of the United States, and it certainly wasn't the generosity of my country either. So quite why he's saying that, I'm unsure about that. Now, we've got increased contagion, of course. Now, I showed you the graphic of the variants. Let's just have a quick look at that there. This is the variant graphic. So this one here, of course, is more contagious than this one here. This one here is more contagious than this one here. So it's the more contagious variants that are taking over from the least contagious variants. So we're getting more and more contagious, but hopefully more and more less pathogenic, which is exactly what we would like. The evolutionary process is coming to our rescue, it would appear, in this situation. So increased contagion, BA2 68.1% of sequence cases, BA2 12.1, 28.7. But as you can see, that is only going to increase. No question that is going to carry on increasing, and the BA12 one is going to take over from the BA2 as the BA2 took over from the BA1 because of increased transmissibility. Janet Woodcock, FDA, I think she's temporary director, isn't she? It's hard to process what's actually happening right now. Well, actually, I'm not sure that it is. I think it's pretty straightforward. Which is most people are going to get COVID. Yes, correct. Well, I don't quite see why that's hard to process, but that's what she says. Most people, pretty well, but I can't see who's going to avoid it, really. I think everyone's going to be exposed. Whether everyone becomes symptomatic is not everyone will become symptomatic, but everyone's going to be exposed. I can't see too much weight around that, really. Anyway, what we need to do is make sure that hospitalizations, hospitals can still function. Transportation and other essential services not disrupted while this happens, which of course is true. But quite how Dr. Woodcock from the FDA proposes to do that, she doesn't spell out. My money is on natural immunity. She doesn't say why she doesn't really elaborate further. Just to reinforce this, London School of Hygiene and Tropical Medicine, new antibody saliva test. Now, so there's a new antibody saliva test. Now, I was aware of this, but this is being rolled out now on a big sort of large-scale basis in terms of testing. Now, I feel that prior to vaccination, everyone should have an antibody test. And if they test positive for the antibodies, I don't know of any evidence that suggests vaccines provide additional information, but I do know of evidence that indicates that vaccines have side effects. So ideally, we would be testing everyone for antibodies prior to vaccination, but of course we're simply not doing that. I don't know what my antibody status is. I've asked my GP for it, but he says they don't do it. He won't do my vitamin D levels either. It's all cost related, of course. Cost and resource related. But there's this antibody saliva test. London School of Tropical Medicine and Hygiene have done this in collaboration with others. And they found out that 97% of secondary school pupils tested positive. Now, this is a saliva test, so this is very encouraging, because what this means to me is that this is demonstrating immunity in the upper airway mucosal compartment. It tells us nothing about antibodies in the blood, because it's testing for antibodies in the saliva, which have come from the mucosal compartments. So I'm very encouraged about this mucosal level of immunity, which we've talked about before, of course, which is a vital part of the adaptive immune response, as the specific antibodies and sensitized T cells and B cells in the mucosal compartment before the virus gets even into the blood. And remember, of course, this makes perfect sense, that the most common feature now for COVID, with a percentage of 84, is it? Let me see. Here we have the list we looked at yesterday. Runny nose, 84%. There we go. Runny nose, 84%. Sore throat, 69. Sneezing, all upper respiratory tract symptoms as the most common features. So consistent with this idea that the virus is being stopped at the mucosal level. So 97% of secondary school pupils tested positive. So basically, they virtually all had it. Okay, there's a few percent haven't. But of course, the 3% there that haven't tested positive, they could have had it a couple of years ago, well, 18 months ago anyway, or a year ago, and the antibodies have simply declined. That's quite possible. Of that 97%, 46 were vaccinated and 51 unvaccinated tested positive for the antibodies. So basically in that population, we see that people are getting immune even if they're not vaccinated. 46 vaccinated and tested positive for antibodies, 51 unvaccinated tested positive for antibodies. Now, this wasn't because, as far as I know, because they were testing for particular types of antibody. It was just on the records that that number had been vaccinated. And again, consistent with the younger age group here, latest ONS data, we see that 83.7% have now natural immunity, have antibodies, and the vast majority of those have not been vaccinated. So again, very encouraging. Now let's look at this video from China. Yeah, I'll just show you. It's just very briefly. I'll just show you it. It's a YouTube video. I think that just gives us the idea of the distress in Shanghai, that people have been locked down now. That video was taken after about 3 weeks of lockdown in China. It's now into the 5th week in Shanghai, where the majority of the population are still locked down. This is just difficult to explain. Let's look at China, Beijing, 54 cases. Ban on dining in, ban on people are going to get tested before they go into positive places. Labour Day holidays come up in China, which is quite a big deal. I think it's 5 days, so people are going to be very nonplussed if that holiday is unnecessarily curtailed. Beijing, they've prepared 4,000 temporary hospital beds. Shanghai, 10,700 new cases in the past 24 hours. So we see, and I think we need to be quite clear about this, it was well over 20,000 a week or so back. In Shanghai, this lockdown's working, of course, but at what cost? And preventing the spread of natural immunity throughout the population. What they should do, I believe, is the people that are... We know that the Sinovac vaccine is effective after 3 doses. It's not good at preventing hospitalisation and death after 1 dose. It's not good at preventing hospitalisation and death after 2 doses. After 3 doses, it is very, very, very good at it. So surely we just need to guard the vulnerable people and go around and vaccinate them. The resources used for that would be thousands of times less than testing the entire population 3 times in 1 week. That's 75 million tests. Why are they sticking with this policy when there's such a viable alternative to save lives? We have looked at the reasons for that before, of course. The new cases in Shanghai are in quarantined or restricted groups, so it is working. But as we noticed recently, air travel is still going into Shanghai, and that just brings the infection back. So why they don't just guard the vulnerable and give them a 3rd dose of vaccine, rather than spend all this effort on all these people going around in hazmat suits? And it really is a chilling Orwellian picture. So why they don't follow that simple strategy, which is so obviously the best track to take, in my view, is really quite strange, but they're not. So there we go, a tale of 2 approaches. China, 0 COVID. Denmark, let it rip. United States, let it rip, but they don't quite say that. United Kingdom, let it rip, but they don't quite say that. Thank you for watching.